Okay. Acute kidney injuries can be defined as the rapid reduction in kidney function as measured in a couple different ways. First, the buildup of nitrogenous waste as measured by BUN and serum creatinine, and then second, as a decrease in urine output. Now, urine output can be defined in a couple different ways. So let's start out with anuria. Anuria means that you have less than 50 mils of urine output per day. Oliguria is between 50 and 500, and non-oliguria AKIs have greater than 500 mils of urine per day. You will need to know this and be able to identify, based on a patient's urine output, what kind of define their urine output based on these three definitions. These also come into play as we describe different types of AKIs. Now, one thing we do need to be definitive about is what is an AKI. One of my biggest pet peeves outside of calling BUN BUN is people who misidentify AKIs. We'll have a patient who's on vancomycin in the hospital, their serum creatinine increases by 0.1 or 0.2, and they'll say, and I'll get a call from a pharmacist saying, oh my gosh, this patient has an AKI, we have to stop the vanc. This is not true. It is normal for our body's serum creatinine to fluctuate a little bit between 0.3 milligrams per deciliter per day. So once you get above that 0.3 milligrams per deciliter per day within 48 hours, that is when you can have an AKI. Another way you can have an AKI, and this is according to the KDIGO guidelines, is an increase in serum creatinine greater than 1.5 times their baseline, which is known or presumed to have occurred within the prior 7 days. So, for example, if somebody has a baseline serum creatinine of 1.0, in 7 days, if it goes up to 1.5, that is an AKI. And remember, these are all OR statements. And then the other one is OR having a urine volume of less than 0.5 milligrams per kilogram per hour for 6 hours. Now, this urine volume one is an important definition, as urine volume really is the first indicator of an AKI. It can take about 48 hours for your serum creatinine to respond, versus urine volume does respond quite quickly. So, especially in the ICU, this is the one that people will see the first, or in the hospital setting, this is the one that people will see first. But all three of these are considered definitions, and they are OR. Now, it is good for us to note that there are some staging of the AKI. You have the Rifle criteria, the Akin criteria, and the KDIGO criteria. The KDIGO criteria is the most recent and would be the one that you would probably see the most in practice. I just put these on your slide so you guys could identify the different types of criteria. You will not have to be able to do this on the exam. I just don't want you guys to, be slack-jawed and open mouth whenever somebody asks you on rotation about how we stage AKIs. You can give these three answers: Rifle, Akin, or the KDIGO. And you'll see here that for risk or stage 1, those are all actually your baseline, the patient has an AKI. And then it goes all the way up to a greater than threefold in stage 3 or failure. The difference in the Rifle criteria, loss, is if it's greater than 3 weeks, and then end-stage renal disease is greater than 3 months. And this is renal replacement therapy. So at that point, the patient has chronic kidney disease because they've had greater than 3 months of symptoms. So it does seem like that is not an appropriate part of an acute kidney injury diagnosis, or as you're trying to stage acute kidney injuries. So again, these are the ones, you don't need to know these. I just want to make sure you guys were aware that these can be staged. Now, our next section is on pseudorenal failure. So, in order to appropriately describe an AKI, you also need to know what can cause changes in serum creatinine and BUN without actual changes in renal function. And that's what pseudorenal failure is called. So, it's a false elevation in BUN or serum creatinine. There are a couple different drugs that elevate BUN, including steroids and tetracyclines. The way that they do this is typically by an anti-anabolic effect, where you have a decrease in protein synthesis and an increase in nitrogen waste as a byproduct. Because if you think about it, proteins are made of amino acids. Aminos has a nitrogen product in it, or there's nitrogen in the word amino, or whenever we think about like in organic chemistry, we talk about amino. So that's how that nitrogenous waste really builds up. And then we also have agents that interfere with the secretion of serum creatinine at the level of the nephron. So that's where these like little transporters here that would secrete the serum creatinine into the urine get blocked, and it keeps it into the blood cells, and so you're going to have an increased serum creatinine due to that. There are a couple different drugs that can cause this. One is Bactrim, cimetidine, which why are we using cimetidine? We know that it's kind of a gross drug anyway. Triamterene, probenecid, dronedarone, and colostat. I would like for you guys to know these just so that you can be able to identify them if a patient has an elevated serum creatinine.